It's not unusual for me to be asked to give the name of a good doctor. Well, I think I have one. Dr. Sony, who is using her medical knowledge and her overall intelligence to improve the health insurance coverage for millions of Californians. Take a listen to what she has to say.
I am the Chief Medical Officer of Covered California, and I oversee a few divisions also within the organization. And I've been lucky enough to be part of Covered California for the last 3 years. We were created out of the Affordable Care Act over a decade ago, but we are a state agency made up of Californians who really do the work for the love of other Californians and for the mission. And so we're not an insurance company. We really are here to try to improve health of all Californians and reduce the number of folks that suffer from being uninsured and the consequences of being uninsured. And there have been a lot of challenges to the Affordable Care Act. It's actually the most litigated piece of law in the history of the United States of America. So it's tough to even keep track of where we are. But back in 2010, this really was the biggest piece of healthcare law and reform to come through. It came through under the Obama administration. And so at times we recall people calling it Obamacare. There
Mhm.
were several important pieces to it. One is things that are incredibly popular, like allowing your kids to stay on your own insurance plan until they're 26, not allowing pre-existing medical conditions to be a barrier to getting coverage. And then the other two were that states were offered the ability to create their own state-based marketplaces where folks that can't get insurance through their workplace, don't qualify for the Medicaid program based on income, are not old enough yet to get Medicare could actually buy their own insurance and get some financial help to do so. So that's where Covered California came. And then the last prong was that states were afforded the ability to expand their Medicaid programs. So if you were a low income individual without kids and who was not pregnant, you would not qualify for Medicaid in most states. And that changed with the Affordable Care Act. So a very big piece of legislation. We peaked at supporting nearly 2 million Californians, which was incredible. We have faced a few headwinds over the last year or so. So our overall enrollment is down a bit. So, but it's still about 1.8 million Californians across the state, and it's hardworking folks from way up north to the border who are really thinking about where their dollar is best served, and especially in an expensive state like California. And I feel very proud that we have been able to maintain better affordability and more support for Californians than certainly the federal program and many other states. So it's tough times right now. I won't sugarcoat it, but I still feel proud of what we've been able to do. I've been a Medicaid provider my whole career, and so I really didn't know who's the marketplace or exchange population. So our average age is about 45, so it's a younger demographic, which isn't surprising given again kind of the sweet spot that we serve. Very diverse. It doesn't fully reflect the diversity of California, but about 25% identify as Asian American, about 25-30% identify as Hispanic Latino, the next largest portion white, and then a smaller portion Black and other multiracial other groups as well. I think the most compelling statistic I can give you about demographics is that over 60% are at 250% or below of the federal poverty level. And in California, that might be, $60,000 for a family of four, $65,000 for a family of four. Very tough, right? To make the dollar extend for that income level in California. So these are folks that are working hard and still really struggling to make ends meet. And that's what they tell us when we ask them or survey them. Farmers, small business
Farmer.
owners, hairstylists,
Yes,
gig
yes,
workers,
yes,
contractors,
right.
part-time workers who just don't get benefits through their employer. Over the last decade plus, we have lowered the uninsured rate to 6%, in
Mm.
part because of the Medicaid expansions, but a meaningful part because of Covered California's existence. So I don't, these were not folks that I think had options or choices before. People that were here in the beginning of the Affordable Care Act that covered California will talk about that first open enrollment, people being lined up around the block, people
Mm,
crying because they had pre-existing conditions,
mm.
history of breast cancer, had never been able to get maintenance screening and follow-up because they could not get insurance before. So this was life-changing law.
Was it they could not get insurance or they could not afford insurance?
Both. I mean, pre-existing conditions. I mean, I'll tell you a story. The summer between medical school and residency, I didn't have insurance. I was not covered by any of my academic institutions. And so I went to try to get my own coverage. And because I had seen a dermatologist once for a little bit of acne, I was rejected.
Oh,
Pre-existing conditions was no joke. So there are folks there who could not get insurance, as well as those that were priced out of it. The folks that wrote this law were intending to leverage market forces for benefit. We're intending to leverage competition for the benefit of all of us to try to lower costs. And in California, we have had a very stable marketplace. So we have anywhere between 12, sometimes up to 15 health plans across the state, multiple health plans in any county that you live in that you can choose from. And again, you get financial help for any of the plans that you choose, depending on your income level. And we literally call it that you can shop and compare. Look, is my doctor in this network? How much will I get for this? How much support will I get for this plan? Do I need sort of richer out-of-pocket benefits? Do I want a lower deductible? All of that is what the consumer or the individual can make a choice on. There is a ton of considerations, and I will say we are very thoughtful in California. Healthcare is not easy for any of us. You know, I was actually just texting with a close friend. She's trying to figure out what plan to buy on Covered California. It's not uncommon that people still make their way to me to say, "Hey, I've got questions and I'm struggling to navigate it." But we've built all of our tools and refined them over the last decade based on that feedback. So coveredca.com is our website. It's built to be easy to navigate, where you put in just a few simple pieces of information about yourself and your needs, how
mhm.
much healthcare you think you might use, and then it, provides options to you. Almost, I mean, I don't want to use this analogy, but almost like an Amazon, where you can sort of see here are other things, other choices that you might want to take a look at. But we still have over 50% of our folks that they just need a human touch to go through this. So we have a service center, folks on the line who are here free to help you. And then there are navigators and agents in the community, enroller partners, over 16,000 across the state of California for free, who are here also to help people make that choice. Overwhelmingly, when we ask folks what played a decision, what was the largest decision, what was the largest factor, it is cost. But I want to caveat that we have we have PPO products, and we have the highest tier, which in our marketplace, or all the marketplaces, is called Platinum. Those are folks who have leukemia. Those are folks who know that they have a high risk pregnancy. They're making different trade-offs than just let me get the cheapest thing and get through this. They need to get to their specialist.
That's a good point.
Yeah.
That's a good point.
Our average tenure is about 15 months, very short as compared to really any other type of insurance. We are meant to be a bridge, but as you mentioned, there are folks who are, copy
Transitioning.
copy
Right,
editors, or,
right.
Uber drivers, and those folks do tend to stay with us a little bit longer because there aren't other options for them.
Have to talk about the big, beautiful bill.
Yeah.
How has it affected covered California?
Yeah, we a little bit got a triple whammy. So we had the enhanced premium tax credits, which made a lot of news last year. It was the reason that we had the longest federal shutdown in the history of the United States, was about the enhanced premium tax credits. That expired in December of 2025. We also, in HR 1, or as you refer to it, a big beautiful bill, there were provisions about lawfully present immigrants who could no longer get federal financial support. We have, 125,000 of folks in that category in California who were going to lose their federal financial support. And then there were a number of provisions just that were red tape. kind of put forward directly from CMS or through that big beautiful bill. So there were sort of three different ways that we were receiving federal policy changes at the same time, all kind of colliding at the same time. So we lost about 100,000 folks because of the loss of the enhanced premium tax credits and the affordability. The group, yeah, the group hit the hardest were middle income families. They essentially have no financial support anymore, and they saw their premiums double, triple, sort of astronomical rates.
Okay, so let me try to understand this a little bit better. The very persons that the marketplace was created for, the people kind of stuck in the middle, found themselves being eliminated because they couldn't afford the premiums.
That's right.
And so then they just go back to being without insurance.
Correct.
And there's no safety net. I mean, they don't qualify for Medicaid at this point. They
Because of
do.
their income's too high.
Their income's too high. They can't afford the premium. And so they're just without. Do they have any safety net? Is there anything for them?
No, I mean, in some counties and some regions, there are, some cash pay options or cash pay programs, but that only gets you so far. And we know that, this is a group that is particularly susceptible to medical debt, right? These are folks that will delay care and crash into higher acuity needs or the emergency room or the hospital and end up with a bill potentially higher than the premium was. So it's a very precarious and challenging situation. And I think that's why you see a lot of anger right now about healthcare because it is this forgotten, neglected group that represents a lot of Americans right now.
Okay.
Yeah, so also in the Big Beautiful Bill or HR1, there were some specific provisions um, adjusting how much federal dollars could go towards SNAP. SNAP is an income-based program too, so the eligibility looks closer to Medicaid. Generally, this kind of middle income family is on what we call a benefits cliff, where there's really no help anywhere for that segment of the population. And it was the first time with those enhanced premium tax credits that they had ever gotten financial help for insurance. And that's why we saw this huge growth for us, almost a doubling of that segment of the population with that support, because people had been waiting in the wings. People had been struggling to figure out what to do. I mean, these are families with kids who are going uninsured who make six figures. This is, sort of wild to think about the economics of it.
Threaten the existence of covered California?
It didn't threaten the existence. There were eras earlier in the history where things like repeal and replace were being discussed, and that was a little bit more threatening than this current era. I would describe this current era as a almost like a picking away, like a rotating and picking
Mhm.
away, things that don't sound particularly glamorous or sexy are sort of happening.
Mhm.
And so it's more challenging to be able to maybe gin up outrage about it because some of it's very technical and very specific. We're lucky in the state of California last year and, excuse me, for 2026 and for 2027, the state of California, the governor and the legislature allocated extra money to us, $190 million and then $300 million to try to save some of those lower income folks to try not to lose them. So we did better than other states did and the federal exchange did.
So what would you say to someone that finds themselves caught in this predicament? What advice would you offer?
I would say first, still come to us, still call us, still check our website. Like I said, we have state dollars that we are deploying in new and different ways. We got more money for 27 than we got in 26. So it could have been that you didn't get support this plan year, but you might be able to get support next plan year. So this is not a situation where, you're like, I'm out. keep checking in with us, keep talking to us. This is a rapidly moving environment,
Hmm.
whether we like it or not. So that's number one. I think number two is there is broad awareness of this challenge. And so, even within certain counties, within certain communities, people are rallying and trying to think about what it looks like to wrap services around folks that might be forced into being uninsured. And so, we're trying to collate some of those resources and share it, but there might be other community-based organizations that also have some awareness of those local resources. So, it's depressing, but not hopeless, is what I would say.
Right. And the bottom line is if persons without insurance end up in the emergency room,
Yeah.
costs are generated, which will eventually filter out to all of us.
Absolutely. And let's walk it through in even more detail, which
Yeah.
is, this year we sit down with our health plans. We're an active purchaser. So we sit down and negotiate premiums every year. We fight for Californians. And not most states don't have that ability or that authority. And very clearly, our health plans were saying things like, yeah, well, because the hospital is anticipating more people without insurance or what we call uncompensated care coming in, they want to increase their rates, and that's why our premiums are going up. So we on this side are paying even for changes on the Medicaid side. Nobody is immune to this.
Right, right. Yeah, that's the part we sometimes miss in
Yeah.
the translation of it all.
Yeah.
Hmm. How did you get involved in all of this?
I think I'm nosy. I think I'm nosy, and so I'm an internal medicine primary care doc. I, grew up trained in a Medicaid environment, practiced in the county. When I first started my career, this is full-time clinical, but there were just like funky stuff in the system. And I actually had a small practice on the academic side, which is more like a private practice. So I had both. I had the county and then I had my private practice. And I would cross the street, literally cross the street, not hyperbole. And on one side of the street, someone would be waiting 6 months for an MRI. The
Mm,
other side of the street, someone could get it same day. And I
mm,
was like, what? I don't know. I'm not sure I feel comfortable with this. This isn't working for me ethically. And I just started to ask more questions and I was more curious. What does the economics of this look like? What do our capitation arrangements look like? And I think because of both being embedded in patient care, seeing the problems firsthand, being curious, and feeling agency. Like I felt empowered to be like, that's not how we're going to run things here. We need a new pathway for expedited imaging, when needed. My scale and scope of responsibility, I think, just continued to grow. And I never felt daunted by the finance piece of it. Even though I'm a doctor, I was like, I don't know, I could learn that. Someone just teach me that. I'll just learn that. And that opened up opportunities like Covered California to me, where I think about affordability as an equity issue. And I think about it in the ways that my patients experience it. If that drug is $50 and I don't have it, my medical plan is an unsuccessful medical plan. The economics and the medical care are intimately connected. I think I have brought all of those skills and lived experiences and just a passion for the work. So I think they
sure,
made the right choice.
sure. And you continue in your clinical practice
I do. I still see patients in the county, not as much as I used to. It's just one day a week, but still on Fridays I'm there.
and the private practice also?
No, just in the county, which is really I left the private practice after that first year. That wasn't my environment to be practicing in.
Oh. Tell us a little about your background. How'd you get to be a doctor?
Yeah, there was I think frankly my mom was surprised I ended up being a doctor. I was a very kind of outgoing, kind of performance arts type kid. I think she thought that would be what I would do with my life. But I was academically minded and focused and practical too. And when I got to college, I was studying anthropology and I was studying medical anthropology specifically. And it was a very interesting intersection of things that excited me. I was interested in culture. I was interested in how systems impact lived experiences. and I was interested in the medical field as a particular cultural milieu. And um, that led me down the path of medical school. And I don't think I could have been any kind of doctor. Like, it wasn't just like, oh, I love medicine. I loved primary care. I really loved primary care, the relationship and the continuity, the bidirectional relationship. I loved my patients, and honestly, they loved me. I remember I was pregnant with my first kid, and people who had very little were buying me onesies, bringing me fruit from their trees, buying. I walked past the hallway when there was a tricycle in the hallway, and I was like, this was a real relationship that we had.
That's beautiful. You don't hear about that very often.
That is sad to me. That is how I was trained in primary care. It's what I saw as a model of primary care. And had I not seen that model, I don't think I would be in medicine.
But you kind of glossed over a couple things that I saw in your bio. Where exactly did you go to medical school?
Oh, sure. Yeah, so I'm from Los Angeles, but I went to Harvard for college and Harvard for medical school. And that was my first time back east. It was a real culture shock. And I'm very grateful for it. I think I got some thicker skinned, and I also think I was very rigorously trained. I mean, I was trained to be excellent clinically. And frankly, the mission of Harvard Medical School is to build leaders. And so there is a little bit of hubris in our medical education, which I think has served me well, which is, I don't know, why can't I fix that? Why can't I do that?
Right.
Let me try.
Right. And the fact that you are trying is very reassuring. And are you, I guess the word is optimistic about the future for Covered California, and for those persons that might find themselves in an uncomfortable position right about now.
I am an optimist generally. I would not say I am optimistic in this moment about what you have just outlined. These are really tough situations folks are facing. I was at a community event talking about some of these regulatory and policy changes, and a covered California enrollee stood up to ask a question. And what
Mhm.
she told me, she said, you know, so she walked up, she had a cane, she clearly looked like she was somewhat frail. And she said, I just got my premiums and my out-of-pocket costs and for next year, which she was talking, this is last year, talking about this year. And I have some new medical diagnoses. I have three specialists I have to see. I cannot afford this. And then she looked at me and she said, Dr. Soni, what am I to do?
Mm,
And in that moment, I mean,
mm,
I'm a primary care doctor. My heart and my heart of hearts, like, oh, I mean, I crumbled on stage. I was like, I'm not going to pretend like I have a solution for you. I'm not a smooth talker. Like, I'm here to tell you this is a tragic situation. I mean, I thought about it and I thought about her, and I did come up with some tricky, interesting ideas that I sent to her by email afterwards, but no, not everybody is going to land on their feet in this moment. And
mm,
even the changes on the Medicaid side, there are estimates of the number of people who will die because of these changes. That's not hyperbole. That's the reality that we're in right now. So, no, I don't feel optimistic in this moment, but I feel resilient that we can rebuild afterwards.
mhm,
You know, I want to share a little bit about what my team at Covered California does, because I think while I cannot share some of the I cannot change some of the policy um, headwinds that we're facing, we continue to do incredible work, and I think we're best in class in a few areas that I want people to be buoyed by some of that. One is we have, 2 million people is not a small number. So it's a very rich set of information. We have race and ethnicity, language, regions, if you're in a rural area, all this interesting demographic data that you asked me about. And we don't just, have health plans that people can choose. We want to make sure that those health plans are delivering on the value. If you got someone working hard for $1 and having it go to a health plan, are we getting value out of that? And so we stratify our data on health outcomes by everything you can think of. Like today, someone could go online to our website and see what's the rate of breast cancer screening for Vietnamese women in the Central Valley, like that level of specific benchmarked
Mhm.
against others, trended over multiple years. And so the richness of the data, our transparency about the data, and that we turn that into action. If we see disparities, we go right back to those plans and we're like, this is unacceptable. And what are we going to do about this together? Because it's shared accountability for that. So that's one thing I want to highlight, which is we take the work of health equity very, very seriously and hold our health plans accountable. California is an activated environment. There are other advocates that got the law in place that gives us the data to be able to deliver on, a product like that, a dashboard like that. So it's others who have come before us. And then absolutely, I think our team didn't take it as a checkbox exercise. We were like, how do we really turn this legal requirement into something meaningful and action oriented that we feel proud to deliver upon and can be best in class? So I think it's both of those things for sure. It's really dedicated people in the organization and outside of the organization.
Are you a state-funded agency?
It's even more interesting. We are technically funded by the people we serve. So a percent of premiums, the plans have to contribute for our operating costs. So we have aligned incentives. We want to be as lean as possible to not inflate costs for the people that we serve. We literally work for the Californians we serve.
So I don't understand that. Explain that a little bit more.
Yes. So for the 2 million people that are covered, been covered California enrollees, there's a
Yeah.
set, they all they pay some premiums, there's some federal tax dollars, there's some state dollars. A percent of that total premium pool is what funds our covered California staff and budget.
So that would speak to we would want to increase the premium because we would have get a higher percentage.
But
Am I?
not really for us. Maybe for a health plan, but not really for us. For us, because we're in service to the covered California enrollees, when they say things are too expensive, we go back and figure out how to tighten our belts. We go
Okay.
say, okay, we got to lower the cost. We're not going to be the cost driver here. Someone else might be the cost driver. It's not going to be covered California. I'll offer one more glimmer of hope story,
Okay. All right.
which is not only do I think we do a good job as this active purchasers, I do, and maybe it's an overused cliche term, but I do think we try to innovate. So as an example, we have a program where we hold all of our health plans accountable to just a few metrics, diabetes control, blood pressure control, colorectal cancer screening. If they didn't hit a certain benchmark, they had to pay, downside risk for them. And we were in a position where we said, well, what could we do with those funds that would meaningfully improve the health of Californians? And so we launched some innovative programs in response to learning about real food insecurity in certain portions of our population. We took, in the first year, $10 million of those money and put it in the form of a reloadable debit card for Californians. There are now 13,000 Californians across the state that have a card that they can use at any food retailer to address their food insecurity. And we embedded a comparison arm to study it to make sure that it actually worked. And we have these interesting early results, both quantitative and qualitative, showing that we've reduced stress, reduced depression, that people are losing weight, that they have better chronic disease control just for getting a little bit extra money every month to support their grocery shopping. I mean, that's the kind of work that we're trying to do.
And do you put restrictions on what they can buy?
We do not. We do not. And that is a philosophical stance, but I also think it's an evidence-based stance, which is, and I think when we are able to publish some of these results, it will become clear. People deserve freedom, respect, and autonomy. And
Mm.
if you give them freedom, respect, and autonomy, they will make the right choices for themselves. Overwhelmingly, I believe that to be true. We don't have to tell them to buy the apple. They will buy the apple themselves. We believe that it is our mission to be of service to who we serve and to change the narrative, honestly, to start to make the art of possible more widely known so that when we do have opportunities again, we don't have to go back to something that wasn't working for us all. Let's already put the future model in place. I'm always like, if I can be of help to anybody, you let me know because I do think the clinical voice and the clinical experience is so important. This is meant to be healthcare at the end of the day. So it's a very close-knit community, but we're not all resourced the same way.
It's reassuring to know that in the face of what appears to be not so great news and people suffering, that there are also people equally invested in making it better.
Thank you.